So a hernia is simply the protrusion of an organ or other part of internal body through a weak area in the usually abdominal wall. Hernias can occur in a variety of situations. The common ones that are often thought of are groin hernias in men, but also women can get hernias, particularly at the belly button, as men can too, and at previous scars from surgery as well. And lots of people have heard of things called hiatus hernias, which is herniation of the stomach into the thoracic or chest cavity. So this is something that's not really talked about very often. As surgeons, we're used to meeting patients that are complaining about a hernia and they want something done about it, but often by that point it's too late to do anything to actually prevent it. There are probably 3 or 4 things that you can do to prevent a hernia if you haven't got one already. Number 1, try and maintain an ideal body weight. So obesity, we know, puts extra pressure on the abdominal wall, and that means that the weak areas like scars and in the groin, which is a naturally weak area, particularly in men, can be stretched and hernias can develop. The next thing is to avoid doing things that can actually put a lot of increased pressure in the abdominal cavity. So that might be lifting very heavy weights in a unprotected manner without a support belt, etc. Or it might be simple things like chronic constipation or chronic difficulties passing urine, which occurs with men with prostate issues. And then chronic cough, so from smoking, is probably the final cause of prolonged increase in abdominal pressure. The next thing is don't smoke. Smoking, we know, weakens the tissues in our abdominal wall, and over time it obviously causes changes to our lungs, which cause a chronic cough. So there's a double whammy, if you like, whereby the cough increases the pressure in the tummy and the smoking itself weakens the tissues of the abdominal wall, which means that hernias are more likely to occur. And then I suppose the final thing to say is that if you do spot the early signs of a hernia, and that's usually a swelling, try and get medical help to diagnose it so that it can be treated before it gets large and actually starts to cause symptoms and possible dangerous complications. So unfortunately, once you have a hernia, that's it. There are perhaps things that will stop them getting larger over time, so eliminating some of the underlying causes. Some people find wearing a truss is helpful. We tend to not recommend it if hernias are very large, but if they're small and can actually be kept in place with a truss, then a truss can be quite useful for very selected patients. But once you've got a hernia in the main, I'm afraid that's it. It's not going to get better on its own. And over time, it will generally start to enlarge, particularly if you exert pressure on the hernia by doing heavy lifting or having these other things that we talked about, like chronic cough or chronic constipation. So the first and foremost way will normally be by your doctor. So if you see your general practitioner, because you can see a swelling in the groin or at the belly button, they can usually diagnose that it's a hernia. And there's a couple of tests that we use. So I'll let you in on a couple of secrets. So number 1, hernias will usually disappear when you lie down flat. So if you've got a lump that's not there when you're lying down in bed at night, either at the groin or at a previous scar or at the belly button, but then it suddenly appears when you stand upright, or if you put a little bit of pressure on the tummy to sit up, then that is almost certainly a hernia. The other thing to say is that hernias you can often feel that an enlarging or a hardening of the hernia if you cough. So sometimes you'll see doctors popping their hand on the lump and asking the patient to turn their head the other way and cough, and that will also be a way of detecting that it's confirming that it's a hernia. Now, sometimes we see patients with very, very small hernias. So these are hernias that are more difficult to detect by what we call clinical examination. That's just examining the patient ourselves. And in that scenario, if there's a good story of the sorts of symptoms that we get from a hernia, such as a dragging sensation, discomfort on standing or lifting, but we can't feel them, we may then recourse a small number of patients to imaging techniques. And probably the most popular imaging technique is to do an ultrasound scan of the area, because that gives you a very good idea of the anatomy and also the size of the swelling and the size of the defect that the hernia is poking through. And we have some radiologists that we work with who usually have a specialist interest in this area. We don't tend to do things like herniography so much now, where dye is injected with a needle into the hernia to sort of outline it, because ultrasound is so much better than that, and so much less uncomfortable for the patient. In certain scenarios, very, very selected scenarios, we might even have to do a CT scan to look at hernias. And in the case of things like hiatus hernia, that's the stomach going into the chest, you would need to do a special endoscopy to look for the hernia. This is where people like me come in. So hernia surgeons will be the person you'll see to discuss the most appropriate management of your hernia. So if the hernia is symptomatic, we're talking predominantly about abdominal hernias here, so incisional hernias, groin hernias, belly button hernias, then we would tend to recommend repair. And that will be via a variety of approaches. But essentially, the hernia, we said earlier, is not going to go away on its own. If it's giving symptoms, we know that those patients are at slightly higher risk year on year of getting serious complications from their hernia, which I think we might come to in a bit. But so repair in that scenario is the best way forward. Now, this may be via open techniques, so making a cut over the lump, simply stitching the defect back together with strong stitches and then closing the skin over the top. We may use mesh, so plastic mesh, to strengthen the scar so that it heals more strongly. Or we may actually use other materials if mesh is contraindicated, such in patients who are more prone to infection, to strengthen the area. But that's repair. Now, repair can obviously be done by open technique, but it can also be done by keyhole surgery as well. So we can introduce a camera or what we call a laparoscope through a small port in the abdominal wall, and then introduce the mesh through that to actually strengthen the area, repair the defect from the inside of the tummy. And sometimes we will fix that mesh in position with either stitches or what we call special tacks, which hold the meshing in place while the area heals. So this is something that we get asked a lot by patients, because first of all, when they're told they've got a hernia, they're worried that it could be something that could be harmful to them, and then they want to know what they should do about it. Now, we know that a lot of people are walking around with what we call asymptomatic hernias, so there's no problem with the hernia, it doesn't give them any difficulty or pain or discomfort. And we know that in that scenario, the hernia is unlikely to cause major problems to their health or be dangerous. When the hernia starts to become uncomfortable or painful, we know that in that scenario it is more likely to become dangerous. And the way that hernias become dangerous is that if the intestine or the bit of internal body organ that's poking into the hernia gets stuck, we know that the blood supply to that bit of tissue can be cut off by the pressure of it being stuck. And all living tissues need nutrients and oxygen from the blood that flows through them. And if that stops going there, the tissue becomes what we call ischemic, so lacking in blood supply, and then eventually it dies. And when the tissue dies, toxins are released into the system and can cause things like sepsis. So that's the really, really sort of most serious complication. It's called strangulation. And if a patient gets a strangulated hernia, this is an emergency scenario, and patients need urgent surgery to correct the problem, relieve the pressure on the affected bit of intestine, and if it's dead, then it will have to be cut out and the intestine joined back together. So it's a really major procedure to sort that out. And I would say that what we're all about in hernia surgery is trying to prevent that, because that's a much more dangerous outcome than having the hernia repaired in the first place in a very controlled setting before it's caused major problems. So strangulation is what we're trying to avoid. There is a lesser complication which might predict that strangulation is going to occur when the hernia becomes what we call irreducible. So it's stuck. It won't pop back in when you lie down flat, and that's called incarceration, another complicated word, but it basically means the bit of intestine is stuck inside the hernia, and if it's stuck there for too long, we know again that that could lead to strangulation. So those are the two scenarios in which we really worry about patients with hernias, and in which they should really seek urgent medical help, because if they don't, they can become very poorly as a result.